I want to say when it comes to these trigeminal autonomic cephalalgias, the longer the name, the shorter the time. Okay, when we come to where we have to use an abbreviation for the name, we're talking seconds. Okay, that's not always always the case, but it gives you a general to give you a general feel or classification of where you would be. So, if you guys don't mind, I want to go through with the case, kind of go through these diagnoses really with the case, and really coming back to this case so we can kind of figure out really what's going on and get a better understanding of the text. So this case, I'm not a huge fan of reading slides, like, but in this case, I am going to read the slides just so we all have those that may be on the phone or whatever the case is, may not be able to see the screen, whatever the case is, that we have an idea of kind of what case we're dealing with. So we're dealing with a 48-year-old man with a complaint of recurrent headaches over the past 3 weeks. Headaches are excruciating, severe, with maximum pain in the right orbit radiating into the upper teeth, as well into the temple and the ipsilateral neck. These attacks last for about 45 minutes to 60 minutes, and they recur. And he has 1 to 2 attacks every 24 hours, and 1 attack within 2 hours of falling asleep. The headaches are associated with right-sided lacrimation, right-sided photophobia and phonophobia, rhitosis, and intense agitation. Further in the interview, we see that he has a constant low level of discomfort and pain in between the severe attacks. And he also has this alcohol trigger. He's had a similar episodes over the past 7 years, each cycle lasting about 6 weeks, spontaneously resolving with up to 8 months in between cycles. He is a smoker. His workup, including blood work and MRI and MRA, is normal, and his exam done while he's in between exacerbations is also normal. So what is his diagnosis? So this is the point where I take off my coat here. You know, we tend to kind of roll our sleeves up a little bit and let's get to work, right? So when it comes to these diagnoses, right? So is it episodic paroxysmal hemicrania? Is it episodic cluster? Is it migraine without aura? Is it hemicranial continua? Is it another headache syndrome, or don't know yet? Now, a lot of you guys are on mute, so I can't see where people are saying. But let's go for the newest person, like the newest resident or what have you, or trainee that may be with you. Let's go with, okay, we don't know yet. All right. Now, let's explore these criteria. So the criteria for cluster headache, and then we'll relate this to our patient. The criteria for cluster headache is that you have to at least have 5 attacks fulfilling these criteria: severe or very severe unilateral orbital lasting 15 to 80 minutes if untreated, or supraorbital or temporal pain lasting 15 to 180 minutes. The headache is accompanied by at least one of the following: so ipsilateral conjunctival injection or lacrimation, ipsilateral nasal congestion and or rhinorrhea, ipsilateral eyelid edema, ipsilateral forehead or facial sweating, ipsilateral meiosis or ptosis, and then a sense of restlessness and agitation. And then these attacks for cluster occur from 1 every other day to 8 times a day. Okay. Now, and it's not attributed to any other disorder. That's important. We'll get back to that. So the difference, so one of the changes is that how do we differentiate episodic cluster from chronic cluster? Well, it's the pain-free remission period. So if it's greater or equal to 3 months within a year, we'll say it's episodic. If it's no pain periods that last 3 months or greater within a year, we'll say it's chronic cluster headache. And so that is a difference that with the updated criteria back in 2018 that we see with this. So let's do this with review of our patient. So ataxia cluster occurs once a day, or once every other day to 8 times a day. He has 1 or 2 a day. So he has this part. The attacks last for 15 to 18 minutes each. His are 45 minutes to 60 minutes. He has that. Ipsilateral autonomic seizures. You know, he has the ptosis, the lacrimation. He has that. He doesn't have the other things. He has this alarm clock periodicity, right? Periodicity, say that right. And he has this, but this is not actually in the criteria. All right. He also has a trigger, which is alcohol. He has that. That's not actually in the criteria either. And then 30% of patients with one of the attacks report interictal pain, right? He has this, but that's not, you know, that's not in the criteria either. So the challenge we have is, okay, maybe this is a slam dunk cluster headache, maybe slam dunk, right? He's had some recurrent episodes over the last several years, but remember he said he has normal interactive examination and the neuroimagings are normal, like I said, but remember he has this periodic, I mean, he has this kind of this baseline pain where he can have some of the exacerbation. So the remitting form of hemicrania continua is a possibility, but the exacerbations in hemicrania continua tend to be a little bit longer. And so episodic paroxysmal hemicrania possible, but its attacks appear a little bit too long and too infrequent. So the question is, should we give him an Endomethacin trial, you know, for hemicrania continua or paroxysmal hemicrania if the anti-cluster agents don't work? Well, let's go a little bit into the cluster pathophysiology before we actually get into some of the other diagnoses, just to kind of check his case with that diagnosis. So this ipsilateral posterior hypothalamus activation has been shown in cluster pathophysiology. I mean, a lot of different structures involved. You have the trigger, you have the triggers with the, I talked about orexin, everything with the thalamus, where you could get these sleep wake cycle alterations. We think that there's something to do with that as well. The trigeminal ganglia, clearly, because you have some of the CGRP and the VI, vasoactive intestinal protein, so that's VIP. And you know that some of the autonomics travel along the sphenopalatine ganglia, which travels along V2. And so you can get this different activation. And then there's other fibers, other connecting fibers where you can even get the lacrimation as well. And then the superior cervical ganglia, where your sympathetics can be involved as well, right? And so here's the image where we can see some of the different posterior hypothalamus activation that we think is part of the cluster pathophysiology. There are a pre-ictal, ictal, and post-ictal kind of signs or phases when it comes to cluster, right? And so you can see a lot of things. I think sometimes it gets confusing because you can see some of the photophobia, phonophobia. You can also see some of the things, the concentration difficulty, decreased energy, mood changing. This sounds a lot like migraine, right? I mean, there sounds like a lot like some of the associated symptoms that happen in a few different of the migraine phases. So that's where a little bit this can get a little confusing when it comes to migraine. One thing that I always share is remember that there's a sense of restlessness or agitation, right? Which is going to be different from migraine. Usually people with migraine want to lay down, right? They want to decrease their stimulation, right? And then a lot of times with people with cluster, they have this sense of restlessness. That is a key component, at least for me, that I think of. And the other key component is obviously the time. And I talked about that earlier in the grand rounds. So anyway, in the ictal phase, you get the shooting pain, stabbing pain, sharp pain, fiery pain. You get all this different pain syndrome, and that's what people have described it as. And then kind of in the post-ictal, you can get some of the things that you had in the pre-ictal, but you also get some of the, including some of the parasympathetic symptoms and the restlessness and mood changes and everything like that. So let's move on to paroxysmal hemicrania. Now, this is different. Remember, I told you as the name get long, the headache gets shorter, right? So here you have to have 20 attacks, right? So the part of the criteria, you have to have 20 attacks, with these attacks fulfilling the severe unilateral or orbital and supraorbital and pain lasting 2 to 3 minutes, 2 to 30 minutes, I'm sorry. And the occurring frequency of this, because all the other autonomic changes, I mean, in fact, when you go across all of the different diagnoses, all the autonomics are going to be pretty, parts of the criteria is going to be pretty similar. And so but the frequency of this is at least 5 times a day, right? Usually greater than 5 times a day. And this is where I talked about headaches reading the textbook because it's prevented absolutely by therapeutic doses of endomethacin. That's the text, that is the criteria for this paroxysmal hemicrania. We had a good question earlier on the endomethacin responsive headaches earlier. And so this is one of those, okay? And then of course not accounted for any other ICHD diagnosis. Oh, and then the change from the ICHD-3 beta to here is again this pain-free periods of 3 months for 3 months or greater for episodic, and then no remission for 3 months or less, or pain-free periods for 3 months or less for chronic. So let's go back to his our patient, the 48-year-old gentleman. He has this unilateral without side shift. He has that, right? He has the maximum pain in the right location. He has the claw-like aching, throbbing, boring, excruciating pain. He has that. He has the ipsilateral cranial autonomic features. He has that. He has the photophobia. He has that. And this is where I said, like some of the people will actually lie still, but some of the people feel like they're agitated, and this is a big difference in clinically, at least what we see a lot in migraine. But he has this. He has to pace during an attack. These attacks can occur spontaneously, but 7% of these patients report the alcohol trigger, which he has. This really doesn't have the alarm clock periodicity. There's really no gender preference. So one of the things I didn't say for cluster is almost the reverse for as far as prevalence than migraine. So in migraine, the prevalence is about 2 to 3 women to 1 man, roughly around that. This is really the reverse. It's like 2 to 3 men to 1 woman, really. The cluster is actually as prevalent as multiple sclerosis, although we think is very highly underdiagnosed, which is why we're talking about it today. We think it's very, very highly underdiagnosed, and not much research as we would like on that too. So anyway, unlike cluster, the attacks of paroxysmal hemicrania is shorter, right, and there's more per day. It's usually 4 to 38 attacks, so but a mean of 14 attacks a day. The mean of the duration of a cluster of paroxysmal hemicrania is about 13 minutes. Actually, the mean, I said going back to the time frame of cluster, we talked about 15 minutes to 180 minutes, so 3 hours. But the average is about 43 minutes, 43, 45 minutes. I get detailed, but about 45 minutes, you can kind of think of that. And then his interictal discomfort, about a third of patients have that with episodic paroxysmal hemicrania, which is same as cluster, and he has that. So with him, it's unlikely to be paroxysmal hemicrania paroxysmal hemicrania, but we may not know without an endomethacin trial. The activation versus the ipsilateral posterior hypothalamus, the activation of paroxysmal hemicrania is actually on the contralateral. So contralateral midbrain, contralateral posterior hypothalamus, and over the red nucleus and substantia nigra is what we've seen in these patients. So let's go on to the next one. And I almost want, I guess I'll do questions at the end, because I almost want to kind of go back and forth and have more of a discussion with this lecture. But again, this is a little bit more challenging to do when everybody's virtual and stuff. But so let's go hemicrania continua. Well, we learned about this a little bit earlier, but essentially this is a headache that's present for over 3 months with exacerbations of moderate or greater intensity. It has one of the autonomic symptoms. It responds exclusively, not exclusively, but it responds absolutely to therapeutic doses of Endomethacin. Yeah, not everybody reads the textbook. And then there is no better accounted for in another ICHD-3 diagnosis. And what's new is that there is a remission period. So the remitting type is where you have a remission period of 24 hours or greater. And then there's an unremitting type, which is no remission periods for 24 hours or greater for greater than 1 year. So again, the baseline, I think the other thing that we have to think about is that with hemicrania continua, the baseline average intensity is a little bit higher. Like his is 6 out of 10. Excuse me, it's 6 out of 10. His was actually mild in between the excruciating attacks. The other thing too is the superimposed exacerbation of the severe pain. He has that. He has the exacerbation lasting minutes to days. He has that part. He has the exacerbations with some migrainous features, which we can see in hemicrania continua. Remember, when I was in residency, I thought the patient that came in, that sounded a lot like chronic migraine, and patient had been treated by a lot of other people too that thought the same thing. See stabs and jabs or foreign body itchy eye sensation. So we didn't ask that, right? We need to have ask that we can see in hemicrania continues, like just like it's something in my eye, like it's just these stabs and jabs, but you just feel like something is in my eye. Sometimes we see that with patients that have hemicrania continua. The agitation, being verbally abusive, or being verbally abusive, we know he has the agitation, and we know that this is innocent responsive. So at baseline, so his baseline intensity seems to be low. The circadian attacks is more common with cluster. So I you know, with this gentleman, I'm still leaning a little bit more towards cluster, but let's work through these other criteria of the attacks. Now, there is contralateral, when we look at PET imaging and hemicrania continua, and this is where I was talking about, like some of the imaging looks very similar to chronic migraine, where there's contralateral hypothalamus activation and ipsilateral midbrain activation, okay? And so it gives a little bit, you know, just a little bit of insight of the imaging that we've seen. And what we're gonna do is kind of go through each one of the imaging, obviously, as you guys can astutely tell. Now let's go through this kind of the last part of the class card. So SUNY, right? So short-lasting unilateral neurologic form headaches. Okay, what are they? They're short-lasting unilateral neurologic form headaches with conjunctival injection and tearing. That's SUNT. And then short-lasting unilateral neurologic form headaches attacks with cranial autonomic symptoms. That's SUNY. The criteria for this is that they have at least 20 attacks. They have the same, kind of almost in the same distribution of the orbital or supraorbital temporal, but they can have other trigeminal distributions as well. These attacks last from 1 to 600 seconds. So about one second to about 10 minutes. And they can start as a single jab, a single stab. In fact, let's go to single jabs, a group of stabs, or kind of this sawtooth pattern, right? And at the top of that, at the peaks of these stabs, the pain is super intense, all right? And so I just want to say, I'm talking about these attack phenotypes, so I just wanted you to kind of see what I mean by that. So single stab or a group of stabs or a sawtooth pattern. This diagnosis also has at least one of the 5 cranial autonomic symptoms or signs, ipsilateral to the pain, and they're occurring with a frequency at least 1 a day. Now, let's see. So with SUNCT, one of the things with SUNCT, and this one has a little bit of more male predilection as well, so like 2.1 to 1. There can be trigger zones, and it's similar to trigeminal neuralgia. In fact, trigeminal neuralgia would be in my differential diagnosis, unless, I mean, you have to almost have these autonomic features and looking for the other parts of it. So patients are not really restless, and they can have a lot of episodes within 1 minute, right? And so they can have hundreds a day, hundreds of these attacks a day. And so this is one of the rarest. What really distincts this, makes the distinctions between this and SUNY is that you have way more marked conjunctival injection and tearing, thus the SUNCT, such as the CT, right, the SUNCT. That doesn't really fit our patient. And when we look at fMRI, there's bold contrast signal in the ipsilateral posterior inferior hypothalamus. So we need to always consider secondary causes of attacks. I believe my first, I mean, maybe it wasn't my first, it was definitely, it wasn't my first, but I remember seeing a patient in my fellowship that came with, I mean, a woman came with these, first of all, she was a woman, right? I mean, not saying that women can have it, but, you know, women do have it, but it's more common in men. She had these cluster-like symptoms. We literally, I was like, okay, we need to look this up, right? We found out that she actually had an aneurysm and actually got fixed, you know, so she had an aneurysm, and that was really what was going on. And I'm not sure how long she had it before she saw me. I know she saw other people before she came to see us and you know, see me in my fellowship. And it's just a reminder that every patient needs a MRI with and without contrast, and then consideration for the MRA. You know, tumors, we have to pituitary and posterior fossa tumors. I mean, really need to rule those out. Those are very commonly will give symptoms similar to trigeminal autonomic cephalalgias. So you can have other things as well, as far as maxillary cysts and some other diseases and things like that. A cervical artery dissection, right? You have dissection that kind of gives these things. So Pancoast tumors. So we definitely want to look at secondary causes and rule out. We have to rule out secondary causes of attacks. Okay, now what was done with this patient? They had the review of the MRI, because they came with the MRI and the MRA. It was normal. We did a trial of Endomethacin, right? Because we just want to rule out, make sure he doesn't have an Endomethacin responsive headache. Trial Endomethacin. And then, and the way we do this trial, I mean, and it varies from provider to provider, is we do a titration, usually starting at 25 milligrams 3 times a day, all the way up to 75 milligrams 3 times a day. I have a certain titration that I use, but basically you just want to gradually increase till you get to therapeutic doses if we can. We don't have the endo spot test, right? So the endo spot test used overseas can actually really can be used to see if patients, if they do have an Endomethacin responsive headache type. Now, so our probable diagnosis within this patient is episodic cluster headache, all right? So what are our treatments? Well, acutely, and one of the things I actually with advocacy now, it's been this oxygen. So high flow oxygen, some people say 7 is usually, I mean, I usually do 12 to 15 liters if we can. A high flow oxygen, non-rebreathing mask. And it's a great abortive treatment. We're actually advocating CMS that they really cover this. This is actually ongoing, like right now. Last week, we sent letters to CMS. They're looking at this because unfortunately, it's not even covered. And so we have to go through a lot to get patients these. And it's a very safe treatment, very effective, and really level A, but for some reason they're not accepting it for Medicare and things like that. So sumatriptan and the zomatriptan, in these cases with the cluster headache, because they're so quick, you know, I mean, in relation to like migraine, you definitely want something with fast acting. So the pill are not going to be as helpful as like the subcutaneous injection or nasal sprays or other other non-oral uses. And then we also have the external vagal nerve stimulation. The specific device is called a gamma core device that has been FDA cleared for the treatment of episodic cluster and potentially actually for prevention, so acute and prevention. And then DHE or dihydroergotamine, which is actually FDA approved as well. And then so transitional treatments, so these cycles that patients can have can last up to a couple of months or so, right? And so sometimes, you know, giving steroids is kind of almost mainstay to kind of decrease. Sometimes steroids won't necessarily decrease the cycle. Sometimes it will, but sometimes it could make the pain less severe during the cycle. Greater occipital nerve blocks, injections with steroids. This is the one headache disorder that we know of, that I know of, that we really want to use steroids in. There's been some other reports with different steroids, things like that, but really when it comes to nerve blocks, in headache disorders, outside of this, there's no evidence that steroids are more effective than any anesthetics. And then the anesthetics itself is less risk of side effects, you know, even local there. With steroid side effects, we thinking like alopecia is one of the big thing, atrophy and stuff like that. You never want to inject in someone's face with steroids. Never want to do that. But this is a transitional greater occipital nerve block, ipsilateral to the pain is actually a wonderful way to do it. And then naratriptan, frovatriptan, you remember I talked about these having having longer half-lives, so this has been used as well. And then DHE, IV or intranasally or IM. Prevention is galcanezumab is the newest prevention that has been FDA approved. And I'll talk about that in just a moment. This is CGRP monoclonal antibody. We also have verapamil, lithium. Obviously, there's a therapeutic window, and we have to kind of watch that and watch other things. But lithium is very effective. Other some anticonvulsants. Verapamil should not be right here in this as a anticonvulsant because it's not one, but it is a high one. With verapamil, by the way, every 80, so people may need high doses of verapamil. So one of the things that I look out for is first degree heart block, right? So we're looking at the PR interval. And so I will get serial EKGs as I go up every 80 milligrams, right? So once I get them 80 milligrams, and maybe do a starting EKG, and every time I go up 80 milligrams or so on verapamil, I will actually check a EKG. Roughly around that time, I will check a EKG, make sure that we're not getting any first degree heart block. And then, like I said, the methylergotamine it can be used too. I have not used that personally though. And then the neuromodulation adjunctively can be used. So let me talk about the trial of galcanezumab in the prevention of episodic cluster. This is, again, relatively new. It's the first and only, in fact, FDA approved medication, FDA approved for prevention of episodic cluster headache. And so what we saw that there was a reduction from the headache attacks. It was like, and they looked at week 3. And so we saw that at week 3 that the galcanezumab was superior to placebo for reducing the number of attacks from baseline. and you can get almost 3.5 attacks. And remember, these attacks are very severe. The one thing with cluster headache, you may hear the term suicide headache and things like that, because of the pain that's involved with these. These are, even when you compare it, there's been some comparative studies, like this is one of the most painful conditions that people can have. Even people that have kidney stones, even people that have given birth, and there has been some publications and things on that as well. So, however, galcanezumab was not effective in preventing chronic cluster headache. And fremanezumab, they did not meet their endpoints. Now, they will argue with you, if you talk to some of the people, they will argue with you that they structured theirs a little bit different, and which is why they didn't get it. But the bottom line is that they was not effective in preventing episodic or chronic cluster type headache based on the endpoints and everything that was chosen and was published. So there are most of TAC treatments are not FDA approved. We talked about Endomethacin. I had a question, the question earlier, and I want to emphasize a couple of things that I talked about. And so it's really unclear why Endomethacin, like what does Endomethacin, why there's Endomethacin responsive headaches. Like, we think that in those related to kind of more valsalva maneuvers, because this helps with some of the primary, Endomethacin help with some of the exertional headaches as well. And we think that that's where the decrease or the change in the intracerebral intracranial pressure, you know, because I mentioned that earlier in our grand rounds. The other thing is that I mentioned the prostaglandin forming the COX, right? And so it is a strong reversible inhibitor of COX, but you know, we really don't know. I mean, we think that maybe there's something to do with nitric oxide donors with this. There was some animal studies that looked at Endomethacin on trigeminal nociceptive firing and the trigeminal autonomic activation, and it had an inhibitory effect in that trigeminal autonomic activation in tested animal and in nociceptive firing. But that's an animal study, so we don't really know. So the answer is, I mean, I did a long answer, but short is that we're not really clear of how this worked and how it exerts its effects in paroxysmal hemicrania or hemicrania continuum. So so hopefully that answered that. I don't know if the same person is on that asked that question, but just to kind of elaborate on that a little bit more here in this lecture, I wanted to do that. And then with your SUNYs, the lamotrigine, gabapentin, carbamazepine, oxcarbazepine, oxcarbazepine have been used as treatments. When Endomethacin cannot be used, whether it's tolerability, other nonsteroidal anti-inflammatories, melatonin, I've used melatonin in patients. I've also, it's not here, but natural supplement boswellic acid. There are some case studies with boswellia or boswellic acid to help reduce the amount of Endomethacin that needs to be used. So that's a natural, kind of a natural supplement that may have some benefit as well, but also, you know, the gabapentin and just using the verapamil and things like that in some of the TAC syndromes. And so there we go. All right, so in summary, we got 4 trigeminal autonomic cephalalgias, the cluster paroxysmal hemicrania, hemicranial continua, and then the SUNYs, which actually have 2 different subtypes of that. The workup is mandatory with these patients. We definitely want to get neuroimaging with these patients, especially looking for cellular or posterior fossa lesions. And, you know, with my experience with the aneurysms and other vascular abnormalities. And so there are some approved treatments for cluster headache. There are a lot of not approved treatments or that we use. The preventive, the external non-invasive vagal nerve stimulator. It can be used adjunctively for prevention. Galcanezumab is approved for episodic. For acute, we have sumatriptan, dihydroergotamine, and then back to that non-invasive vagal nerve stimulator. The treatment of choice are for the hemicrania. So anytime you hear hemicrania, you can think, I mean, that's one way to think about it, is, or not anytime, but most of the time when you hear it, think endomethacin responsive, although that's not FDA approved. And then there are some new targets, right? I talked about targets and molecules in my last lecture in the grand rounds, but there are also some targets too that we're looking at for cluster headache, including PACAP, maybe different types of neuromodulations, different uses for monoclonal antibodies, and indications for some of the existing neuromodulations. So with that, I really, really appreciate the opportunity to share, and want to turn it over for questions, and hopefully we have a better understanding of tax. And we rolled up our sleeves and kind of got to work. Well, it was kind of maybe a working lunch for many of us. So thank you very much.
Thank you, Dr. Charleston. Quick question. When you're talking about the MRI, are you considering any special, not sequences, but like internal auditory canal or any, look at trigeminal nerve precisely, or you just order a general MRI with and without contrast?
Yeah, just really a general MRI with and without contrast. If you are suspecting, if part of your differential would probably include some of the trigeminal neuralgias, then maybe you want to pay attention, right? Because a lot of cases, if there's some compression against that trigeminal nerve with the artery, then you may get a surgery involved to do a microcompressive surgery, decompression surgery, and things like that. So if that is kind of one of your main things, like you're trying to rule out trigeminal neuralgias, then yes, I would agree. The other thing too, and I'm sure you guys have wonderful neuroradiologists and everything, is talk to them too. Like, don't just say, hey, send them down there, or on your note, like we have to do an epic, right? And say, hey, suspecting this, can you, look for this, or whatever the case is. And many of my experience with so many radiologists is that they've been, very wonderful and even helpful when it comes to that. But with and without, and then considering MRA for that vascular. Some neuroradiologists may not necessarily need the MRA. I mean, it depends on when they catch that time of flight and everything like that, or with their MRIs. And so, but I mean, just to be say, you can't go. I don't think you can go wrong looking for that. And again, that's part of my experience with one of the very first cases in fellowship. Had the young lady basically had a aneurysm too. So like, wow, okay. We fixed it, and she got. By the way, we fixed that. I didn't fix it, but the neurosurgeons did, and her headaches went away. Right. I mean, that was it. I mean, you didn't have to treat it. She didn't need any medicine, right? She just needed to get that fixed. And so that's what you're looking for.
Okay. Thank you.
Mm-hmm. Any other questions? It's a great question. All righty. There's nothing. Always check the chat when I'm out. But all right. Well, if there's no more questions or anything, it's been a pleasure being with you all. You're welcome, Michelle B. I just saw that pop up in the chat, and so.
All right, thank you, Dr. Charleston again.
My pleasure, everybody. You guys have a great weekend.
Thank you. You too.